Hi everyone, I'm Dr. Faisel Sayed,
And I'm Dr. Dan McCarter.
and you're listening to Faisel and Friends, where we believe access to primary care is a right, not a privilege.
Today, we're talking to Dr. Francisco Hernandez, National Director of Endocrinology at ChenMed, about decoding diabetes care. Let's dive right in.
Oh my gosh, Dr. Dan, from the airport, this is a first.
From the airport, that's right. That's right. It's good to be with you all.
Thank you for being able to do this from the airport. I know you're traveling. You had a great lecture earlier today. I saw the picture. It was absolutely wonderful to see the residents, and seeing Dr. Gonell with them was even better.
Yeah, absolutely. Absolutely. I missed having you with us.
I really wish I could. I was born in Brooklyn. It's true. Dr. Hernandez, welcome. Thank you so much for joining.
Thank you. Thank you for inviting me.
It's great to have you on. I'm so thrilled that we have you on as our national director of endocrinology, and we've been doing this series with the role of specialists in primary care at ChenMed. But before we get into that, we'd love to hear the meet the doctor. We'd love to know your story about, everyone has an incredible story with why they pursued medicine, why they pursued the particular field, and then ultimately how you ended up at ChenMed.
It's kind of a long and convoluted story, but let's say that when I was in seventh grade, I had a biology teacher who had an automobile accident and ended up having to drop from medical school. And he was given the human physiology class and taught us about the endocrine system. And he made it to be such a fascinating subject. I thought at that time I wanted to do that. That being said, obviously it took a few years because I was still a kid. I mean, I was in middle school, barely. I went on to graduate and started private practice, worked there for quite a bit of years. In fact, I think I probably will be giving myself out in terms of age, but almost 30 years of private practice in endocrinology. Among other things, I also taught some medical students. But then the last few years, I worked as a medical director for a healthcare plan, and afterwards as a chief medical officer for a healthcare plan. During that time, I was very, very stressed out in terms of work, and I have no idea how ChenMed got an image of me, but they contacted me, and I was intrigued by the opportunity to utilize my specialty to reach the masses with the new knowledge that I had in administrative medicine. And this was the only way to really marry those two things together. I decided to join in July of 2021. And I have to say that I have yet to find a negative day. I think it was the best move I took ever.
Wow, everyone has these incredible, compelling stories. There's a moment that hits them in their lives that they makes them decide that, hey, this is what I want to do for the rest of my life. And it may sound unbelievable to someone who's not practicing medicine, but oftentimes this is what drives many of us. That interaction with your professor, even in middle school, had a huge impact on you for the rest of your life.
Yes, it did. And actually, my son, who's also now finishing his residency in internal medicine and pediatrics, had a very similar scenario in middle school with a biology teacher who was awaiting to enter medical school and got him into doing it too. So I guess we share that experience as well in the family.
I love that. I love that. I love that. Well, Dr. Hernandez, as you know, now we have 100 million Americans with diabetes, pre-diabetes. I remember my background is community health, and I remember when I joined ChenMed, I couldn't believe how many patients were inappropriately prescribed their diabetes medication, especially insulin. I couldn't believe how many patients we could wean off of insulin just from educating them with different alternative foods to eat or drink. Is this something that you've seen regularly before joining ChenMed? And if so, what are some of your ideas around diabetes management, especially in the primary care setting?
Well, let us start with the basic fact that most diabetic patients need to change their lifestyle and modify their activity levels. And sometimes we can disguise exercise as just a plain relaxing stroll in a park. It is exercise, but it's not conceived as such in your mind. but it allows you to burn calories and get yourself in better shape, and your metabolism gets accelerated. So it's a beneficial thing. And eating properly, it doesn't matter what medication you're in, it won't work if you don't eat properly. So we have to always go back to those two basic things. And then after that is when medications start playing a role. One other issue is that unfortunately, even at the time in which patients need medications, we tend to forget that it's not just giving them a pill or a shot, but it's explaining the proper use of those things. Given the prescription does not mean they're going to be taken properly. There is an uncountable amount of times in which I saw patients that were taking their medication right before hitting the bed and having hypoglycemic episodes overnight, and they couldn't explain why. And it was because they were taking the medication at the wrong time. So, timing of the medications and proper use of them needs to be explained. Same goes to explaining how to use them in what we call sick days. What to do if you're sick and you're not eating properly. And many patients who are on insulin, unfortunately, think that they have to stop it altogether, and that is the wrong idea. They may need to not use the fast acting insulin if they're on fast and slow acting insulin, but they do still need the basal insulin to keep themselves out of trouble. And they may have to, if it's really, really bad and they're not eating at all, to reduce the dosage even of that basal, but to stop it altogether, maybe one mistake that'll get them into a hospital admission. So all of those things are part of the education that unfortunately we miss. And I think that if we were to do a better job at educating them on that, we could prevent so many headaches. Now, in terms of medications, there are people that can do either without medications or with a simple combination of medications. And they're on convoluted and complicated regimens
Yes.
precisely because everybody saw them. They were not controlled and it kept adding things rather than sitting back and say, okay, let me see what's going on. Explain to me how you're doing this. Tell me about your diet. And importantly, what are your goals of treatment? You are the patient. You're the one that has to live with this. How do you see yourself taking control of this rather than me pushing the cart? Are you willing to take the wheel and drive this yourself? I mean, that's the goal really ultimately, to have them self-manage.
Yeah, that's one of the main issues we see is that unfortunately many of the patients don't even see the same doctor. They'll go to a primary care delivery, they'll get one person maybe in the emergency room will prescribe one medication. They will go in the primary care setting. Maybe they'll just continue the medication, or someone may make some changes, then they'll go see somebody else and someone makes some changes. So in addition to the lifestyle, I mean, we also must look at who's giving the care and are they giving the proper amount of care.
And we have to consider that the best solution is not always to just add something on to whatever is there. Is to find out what is there. Because sometimes the physicians who see these patients have no idea about the total medications they're taking, and they prescribe either agents that will cause a hypoglycemia or a low sugar because it's just too many things together. So they then do not take their medications because they already had a bad experience with it, and it was just because it was improperly done. Or they use the same type of medication, and when you add on more of the same, you may not necessarily get a whole lot more of the effects of it because it's already the same mechanism. You already used the most of it, and nothing else is going to happen by adding more of the same.
Yes. You know, I can't, I can't tell you how many times patients would say on the first or second visit, sometimes by the third visit, that doc, I have to confess something to you. I'm not taking these medicines. Or I'm not taking all of them. They may be taking some of them, but I have these other medicines on hand in case there's an emergency and my blood sugar runs too high.
And we need to understand that. That's why one of the first things that we probably will do better would be to sit back and ask them, okay, so where are we? What are you doing with this medication? What are you doing with that medication? Are there circumstances where you would consider not taking it? And many of them think that once they get controlled and numbers look good, oh, I don't have to take it anymore. And unfortunately, they just go back to being out of control again. So it's given them a good idea of what is happening and understanding that this is not too dissimilar to hypertension. The fact that you finally got it under control doesn't mean you have to stop it. At the same time, it doesn't mean you should double down on it either. So, proper usage and proper understanding of what is the patient's perception and what is our goal and how we intend to get there, making it a common work, a common goal for both of us, makes it a lot better than if we make it only our goal. because we will not be successful. We're not the ones living with the patient. We're not the ones living with diabetes at their houses. We're not dominating 24/7 what they do. We need to impress upon them the best possible approach with that visit, but they have to be part of the equation, not just a happenstance, not just because they're there as a chair or a flower pot. They're there because they are indeed the reason why we're getting together to talk.